Yeah.
Great. It's now 4:02. Thank you everyone for joining today's Adaptive Platform webinar. My name is Kathy, and I'd like to take a moment to introduce our presenter today. We are very fortunate to have Dr. Irene Telias with us today. Dr. Telias is an intensivist at the University Health Network. She serves as the Argentina National Study Lead for the IMV domain and leads the waveform domain within the practical platform. She is also the co-lead of the physiology working group. Her research focuses on determinants, physiological mechanisms, and clinical impact of abnormal patient ventilator interactions during early mechanical ventilation. I'd like to pass the time over to Dr. Telias for presenting to us today. Thank you very much.
Oh, my pleasure to be here. I think we have a very heterogeneous audience, and many here are super experts, and my best guess is other people are like maybe hearing this for the very first time. So I will try my best to maybe give you a few new insights and also try to be clear for the ones trying to understand this very complex topic for the first time. So I hope both groups can somehow feel benefited from this talk. Okay, so Kathy has already introduced me. Okay, and we're going to fly through a few concepts, and hopefully some of the messages will stick in when we are going through. Feel free to write questions in the chats. And I don't know if we will have time for questions afterwards, but happy to answer or stay a little bit later if needed. Okay, so the idea is that this is our patient, and the respiratory drive, we call respiratory drive to the neural output that arises here from the brainstem of the patient, and that stimulates the breathing muscles, in this case, the main one being the diaphragm, and modifies the magnitude or intensity of inspiratory effort, okay? The breathing pattern has different domains. One of which is the magnitude, the strength with which we breathe, and this is what is primarily modified and controlled by the respiratory drive, okay? That's the first concept. Second one is that the respiratory centers in the brainstem that modulate respiratory drive are different than the ones modulating respiratory rate. They're both very intimately related between the two, because between the two, we somehow modulate our minute ventilation, but we have to understand that they're modified by different parameters. Why are all of these basic concepts very important? Is because one, measures of inspiratory effort can be used to estimate the status of the respiratory drive. As you can imagine, very difficult, actually impossible to measure the direct activity of the neural centers in the brainstem. And also there's some indirect measures of respiratory drive that serve as a measure of inspiratory effort indirectly because of this very close relationship. That's one point. There is one very important caveat, is that when we have respiratory muscle dysfunction, so in this case, the diaphragm is not working well, what happens is we can have a patient with very high respiratory drive, but not so high inspiratory effort. So despite these two entities, so the respiratory drive, the neural output from the respiratory center stimulating the respiratory muscles to contract at a certain strength, being intimately related to the magnitude of the effort, when we have this dysfunction, there will be a dissociation. And what is the clinical correlate of this? To understand this, we go back to the basics again. How do we modulate the respiratory drive? Okay. Don't look at the schema yet. Focus on what I'm saying. So the respiratory drive is primarily modulated by something called the chemoreceptor control system. Okay. So we have chemoreceptors, central ones in the brainstem and also peripheral ones in the main artery in the aorta that sense the CO2 and pH levels. Okay. So if we had to, and this is the main modulator for the respiratory drive. So if we were to plot the levels of CO2 with the status of your respiratory drive in your y-axis, so in the x-axis CO2 levels and y-axis respiratory drive, the higher the CO2 level, the higher the respiratory drive in a linear manner, okay? This is what we call the chemoreflex drive to breathe, okay? There is another, in order to understand where our patient is standing, we can model it in a little bit more of a complex way because where specifically the patient is. So what is the patient's CO2 level versus what is the patient's exact respiratory drive indirectly estimated by the magnitude of the minute ventilation. We have to also understand how efficient the patient's respiratory system is in eliminating the CO2. Okay, and this is represented by this other line, and this is what we call the metabolic hyperbola. So it can be higher if the efficiency of the respiratory system is lower, and it goes lower if the efficiency of the respiratory system is higher. For the purpose of what I'm going to explain now, we will forget about this metabolic hyperbola, and we will focus on the direct relationship between a certain level of CO2 and how much this CO2 stimulates the respiratory drive. So the higher the CO2, the higher the respiratory drive. When the patient is healthy and their respiratory muscles are working well, this is true for what the patient's brain wants. This is what we call the brain curve. So for a certain level of CO2, that brain wants a certain respiratory drive and minute ventilation. And what the patient's respiratory system is able to achieve. This is what we call the ventilation curve. Okay, both curves coexist and are at the same level. So for the certain CO2, the patient wants, let's say, 20 liters per minute ventilation, but it's also getting 20 liters per minute ventilation. What happens when we have a respiratory muscle dysfunction? When we have respiratory muscle dysfunction, these two curves dissociate. Okay, so let's take a minute to go through each of them. So for a certain, let's say we start here in the number one. I don't have any animation. So in the number one, for a certain CO2 level, in this case, let's say 25 millimeters of mercury, that brain wants, let's say, 20 liters per minute ventilation. But those respiratory muscles are unable to achieve that minute ventilation because they're weak. So what the patient is actually getting initially is, let's say, less than half, 5 liters per minute, okay? If you get less minute ventilation, your CO2 levels will rise, okay? So you go here. And for these higher CO2 levels, that brain will want even higher minute ventilation, okay? So what is the correlate of this? There are two. One is that this dissociation is one of the origins of dyspnea. When your brain wants something that your brain cannot get in terms of minute ventilation, then you will start having what we call respiratory suffering, which is the dyspnea. The second correlate is that as we move through this dissociation, the dyspnea itself and the dissociation does increase the respiratory drive. So this brain curve becomes steeper. So for the same CO2, we will want more minute ventilation. Okay. The main controller of the respiratory drive is the CO2 levels pH. But in the ICU, things are a bit more complex. Okay, it's not just a closed loop system where you have your controller here. Sorry, they're controlling the respiratory centers, your chemoreceptors that sense the CO2, and then the output, and then you see the difference between what you want and what you get, and then you stimulate, and that's it. There are other modulators. For example, the oxygen levels modulate the response to the CO2. The lower your oxygen levels, the higher is your reaction to a certain CO2 level. Okay? Then we have receptors in the airways, in the lungs, in the chest wall, and even the respiratory muscles that through neural input provide feedback to the respiratory centers to say, okay, I'm having a lot of ventilation, I'm not having sufficient ventilation, or there's irritation that stimulates the respiratory drive. Additionally, a different aspect is that we have higher levels, suprapontine structures that can stimulate respiratory drive. For example, patient is anxious, agitated, on pain, that can stimulate respiratory drive. As I just said, dyspnea itself stimulates respiratory drive. And there are different drugs that act on different parts of the neural system that can modulate respiratory drive. There are systemic factors, such as systemic inflammation. It's a big stimulant for respiratory drive. And through changes in metabolic demands, we're modulating respiratory drive through this chemoreceptor control system, but also centrally. And finally, and very important for our practical platform, the things we modulate on the ventilator, so the tidal volume, the respiratory rate, the flow rates, and PEEP levels, for example, can modulate respiratory drive by modifying many of these parameters, okay? So that's a little bit of control of breathing 101. So from a clinical perspective, why do we care about measuring respiratory drive and inspiratory effort? So because both situations where our respiratory drive and inspiratory effort is very low, which we like to call over assistance, excessive assistance, or sedation, and situations where your respiratory effort, drive and effort is very high, are very common in the ICU, and they can lead to specific deleterious consequences. Okay, so I highlighted in this graph some of it. For example, sleep disruption, diffuse muscle atrophy in the context of very, very low respiratory drive and effort. And then when you have excessive inspiratory effort, then patient self-inflicted lung injury or even injury to the diaphragm. And just to highlight some new findings, so there's been a big study recently published from our group in Toronto, Jose Dianti and Johan Golliger for like really working hard on this, where they did a population-based study on the patients admitted to the ICU at Toronto General Hospital, thousands of patients. And what they really found is that patients with very low, this is low, or very high respiratory drive on the left and inspiratory effort on the right could have deleterious consequences. And the effect in this case was the relative hazard of being discharged alive from the ICU or not. The effect of this exposure on the patient's survival was actually related to the severity of the disease. So in patients with, oh, sorry, I'm really sorry. I think I did, yeah, I put this wrong. This is PF, the blue is PF lower than 150 and the red is PF higher than 150. So if you're less sick, this is wrong, it should be higher than 150. The higher the drive and also willingness of the physicians to liberate you, the better. And the same for the effort. But if you're sick, so PF less than 150, not higher than 150, then if your effort is extremely low or extremely high, there's a high risk of having a bad clinical outcome. The other reason why we measure respiratory drive and effort is because if you look at the main screen of a ventilator, we don't see it. Okay, so this is one of the standard ventilators. On the lower aspect, we have the ventilator settings, and on the higher aspect, we have here the monitored parameters, and nowhere we can see a direct measure of drive and effort. Okay, so we have to look below the surface. When we're looking at the ventilator screen, we're just looking at the pressure that it's applied only by the ventilator. When a patient is breathing spontaneously with the help of the ventilator, this is what we call assisted ventilation. The total driving pressure, so the air distending the respiratory system, both the lung and the chest wall, arise from two sources. The tip of the iceberg, which is the positive pressure that the ventilator is giving, okay? And this is what we see on the surface. We see on the main screen of our ventilators. This is the airway pressure over time, the higher tracing. And but then there's something that we are not seeing, that it's inside the patient, which is the action of the respiratory muscles. I don't have any slide on this, but I will show you with my own body. So when the respiratory muscles contract, what they do is they expand the chest wall. Okay, and when we expand the chest wall, by keeping the amount of molecules of air inside the chest wall stable, what happens is the pressure decreases inside the chest wall, particularly in what we call the pleural space, which is with the space surrounding the lungs. This decrease in pressure inside the pleural space, it's transmitted to the alveoli and the airways, and that generates a pressure gradient between the inside the peripheral alveoli and atmospheric pressure, or the pressure at airway opening, and that drives the air into the lungs, okay, or sucks the air. So that pressure that's happening inside the pleural space, we cannot see it on the main screen, so we have to go and look for it. And this beautiful analogy of the iceberg really highlights that hidden pressures, okay? And the total driving pressure driving the air inside the lung, is the full iceberg. Okay. So that's a little bit of how the respiratory muscles work in conjunction, okay? Being the main one, the diaphragm, but in order for the chest wall to expand, we need the accessory muscles, particularly the intercostal muscles, for example, to keep the chest wall stable and to avoid the chest wall from sinking in when the diaphragm contracts. Okay, so how do we monitor respiratory drive and inspiratory effort? And this road trip, or roadmap, not road trip, we will do a road trip through this roadmap of all the available tools. And I like to highlight all of them, at least superficially, to give you an idea of what each of them are measuring, so that if you have more than one, you can do a multimodal strategy and integrate the information, understanding what nuances each of these tools have. So we said the respiratory centers there in the brainstem are the origin of respiratory drive, but unfortunately we cannot measure that. Information goes primarily, so it goes to the cervical spine, and then the phrenic nerve primarily to stimulate the diaphragm. That's something we cannot measure. The first anatomical thing we can measure in our road trip is the electrical activity of the diaphragm, which we are not currently using in the practical platform. But it's important to understand the physiology. So what we do to measure that, we'll see it in a second in the next slide. But that's the first thing. The diaphragm receives the electrical stimulation, and then it depolarizes, and that depolarization is what we can measure with the electrical activity of the diaphragm. Okay. So what is it? So we put a nasogastric tube here on the left upper corner. We see this little diagram. And this nasogastric tube has a array of electrodes that goes through the diaphragm, through the esophagus, passing through the diaphragm. And it has several array of electrodes. Okay, in this case, we see 4 of them on the ventilator screen. So what the catheter does, it allows it's able to measure the electrical activity surrounding the catheter. And there are 2 sources of electrical activity. One is the heart, is the biggest source of electrical activity close to the esophagus. And the second one is the diaphragm. So here the spikes are the atrial. The first one is the atrial activity. Second one is the ventricular activity. And I don't know if you're able to appreciate, but there's a high frequency oscillation on top of the ECG. This high frequency oscillation, that's the electrical activity of the diaphragm, okay? Which the ventilator is able to recognize and highlights in pink, okay? So what the ventilator does is it takes out the electrical activity of the heart, and only the electrical activity of the diaphragm remains, and then it processes the signal to make it all positive, okay? And so you have what we call the electrical activity of the diaphragm in the lower row. The parameter that we measure when we are using electrical activity of the diaphragm to monitor an estimate of drive and effort is what we call the EDI peak, okay, which is this value, the highest value per respiratory cycle. So it's a good surrogate of respiratory drive if the patient is using primarily their diaphragm and if the phrenic nerve and the neuromuscular junction are intact. If you have any disease that would affect that, it's not measuring respiratory drive. And it does correlate with inspiratory effort. And here I put some examples of a patient with relatively low drive and effort. You see 5 microvolts of EDI peak, very high effort. Here you see 50 microvolts of EDI peak. And this is a, let's say, intermediate effort, but with what we call reverse triggering, which is a type of patient ventilator abnormal interaction or dysynchrony. The other thing you can do with this measurement is that it's a continuous measurement, and you can plot the activity of the patient on top of the activity of the ventilator. Here you see how it's very synchronous. Here the timing is synchronous, but you see the mismatch between the support and the patient's effort. And here you see how the effort starts after the mechanical insufflation. Okay, so it gives you a continuous and also the timing of the effort. Okay, so once the diaphragm electrically activates, it contracts, it thickens. Okay, when it contracts, and this we can actually measure using an ultrasound. So we use a diaphragmatic ultrasound. So we use a linear probe with high frequency, and we place it in what we call the zone of apposition. Here on the left upper corner of the screen, you see the diaphragm. So we take advantage of the diaphragm's anatomy. So there's a portion of the diaphragm that goes just next to the chest wall, highlighted in red on both sides. So it's very easy to be able to see the diaphragm by placing this ultrasound probe in an intercostal space on the chest wall. Okay, and I put some examples again here for you to see. This one is easier to gather, but here we see, so this is the fat on the upper, we go from surface to deep. So fat, then we have some intercostal muscles. And here you see 2 very nice hyperechogenic layers, one on the top and one on the bottom, with some hyperechogenic in the middle as well. So that's the diaphragm. On each inspiration, it thickens. On the left, it's a very small effort, so it's difficult to see it. On the right, we see very strong effort, and we see how it thickens a lot every time the patient breathes. And what we are seeing coming in is the lung into the field. Okay, so how can we quantify inspiratory effort using this method? So we change the mode from B mode to M mode, which you see here the line on the middle of the image. It will go that point over time. Okay, so you sit down, and the diaphragm is the structure highlighted with an arrow, and you see how it's thin, and then it thickens, and then it's thin again. Okay, so that's 1 point over time. And how do we calculate? We do calculate something called the thickening fraction. So we have to freeze the image, and then we measure the thickness at end expiration, and then we measure the thickness at end inspiration, and we do the ratio of the difference between the two and the baseline value. Normal values are around 50 to 30%, okay? And that's true for healthy subjects being at rest, and also it happened to be the value that better correlated with better respiratory outcomes early during mechanical ventilation. Different than with electrical activity of the diaphragm, where we don't have real normal values. It varies a lot even in healthy patients. Okay, so when you have the diaphragm thickening plus the activity of all the other muscles, then you get to the point where there is a change in pleural pressure, okay? So until here, you might have activation of all of these, but if you don't have the coordinated activity of all the muscles, the pleural pressure doesn't change. In order to see that change in pleural pressure, you need to insert an esophageal catheter, okay? Because we cannot measure directly the pressure in the pleura. For reference, I will not discuss the details of esophageal catheter monitoring, but you can go into the PLUG working group's website, where you can download different videos that explain how to insert and interpret. Okay. Here I just want to show you something that it's important to understand what we're doing when we're measuring POC. Okay. So as I explained, we have the esophageal catheter that goes into the esophagus and lies in the and it has this nasogastric tube has a balloon close to the tip. Okay, so this balloon has to lie in the lower third of the esophagus, and there's way to test if it's properly positioned. So in order for you to understand what we measure, I want to show you how it looks when the patient is breathing passively versus when it's breathing spontaneously, okay? So when the patient is breathing passively, the upper tracing is the airway pressure tracing, flow over time, tidal volume over time. And the last one is the esophageal pressure over time, which is a surrogate of what's happening in the pleural space, okay? So when we're breathing passively, the air goes into the respiratory system that expands passively the chest wall, and the chest wall is away from its resting position. The normal resting position is a little bit smaller, okay? So it's pushed away. So the chest wall is trying to come back. With this comeback, it pushes against the pleural space, okay? And that push increases the pleural pressure, okay? This is what we call the chest wall recoil pressure, okay? When a patient breathes spontaneously, you see on this patient is triggering the first breath. You see there is the airway pressure comes down and then pressurizes. Then you have the tidal volume, sorry, the flow, and then the tidal volume. And here on the esophageal pressure, you see how the first breath is active and the second one is passive. So you can see on the second one, the pleural pressure goes up. On the first one, it goes down instead of going up. Okay, so the total effort that those muscles are doing, the pressure that they are doing, is actually not only the change in pleural pressure, but the absolute difference between how much that pleural pressure should have increased if that insufflation was passive versus the actual value of pleural pressure, okay? And this is what we call this difference that we can plot over time if we want, is what we call Pmass, or muscular pressure, okay? And you see that this value of Pmass is slightly higher than just the negative deflection, okay? And we can measure during synchronous ventilation, and also this is a desynchronous effort, what we call reverse triggering. Okay, but this is all these techniques I showed you require extra equipment and stuff, and we are very busy, so we need simple stuff. So once we the pleural pressure change and we're able to generate some flow, we can actually measure things at airway opening. with some tricks. And the two things that we're going to discuss is what we call the P.1 and the P.OC, which most of you are already familiar with because you are participating in the IMB. But I think it's nice to see, the rationale. Okay, so in order to measure this, we need to occlude the airway. And what's the principle, or what's the reason why we regularly occlude the airway to be able to measure P.OC and P.1? I explain how this works. So the respiratory muscles contract, the chest wall expands, there is a change in pleural pressure, it decreases, and that transmits to the alveoli and the airways, and there's a pressure gradient that drives the air in. If the airways are open, each of these compartments, so the alveolar space and the pleural space, act separately. And a pressure gradient is generated between the two, and there's dissipation of pressure, okay? When we close the airway, all of these compartments become one compartment, okay? So any change, thinking of as if it was a bag, any change in pressure in one compartment will directly transmit to the other compartment, okay? So in this case, if when we contract the muscles and the pleural pressure decreases, the decrease should be equal in the alveolar space and the airways, if the airways are closed, okay? And this is what we see on the ventilator screen. This is a patient on pressure support. Again, the flow, the positive is insufflation, negative is exhalation, the pressure, positive because the patient is receiving pressure support from the ventilator. And this is the esophageal pressure that let's imagine it's a direct measure of what's happening in the pleural space. So the patient performed an effort, the pleural pressure decreased, that triggered an insufflation, okay? And you see that the airway pressure is going up and the pleural pressure is going down because the airways are open, okay? What happens if we close the airways? If we close the airways and the flow is zero, there's no movement of air, when the patient performs a contraction, the pleural pressure decreases. But the airway pressure also decreases, okay? And it decreases in equal way and at the same time. Okay, so this gives us a great opportunity to measure what's happening in the pleura without having an esophageal catheter. Okay, so two physiological things to notice here. One is what I just told you, is that this is a way to measure what's happening in the airways without, in the pleura without having an esophageal catheter. And the second thing, and this example is quite extreme, the effort or the patient is doing during the occlusion on the right breath is higher than the effort doing without the occlusion. And that's completely unconscious, okay? For two reasons. One is the diaphragm contracts in a much, much more efficient condition if there's no flow. So for the same drive, you will have more effort. The second is there is sometimes an unconscious reaction to the occlusion, so the drive might increase a little bit after a certain amount of time. So from this maneuver, which is an end expiratory occlusion, we can gather two parameters. One is what the famous P.1. So what is the P.1? Is the pressure difference between the pressure at the start of the effort and the pressure at 100 milliseconds after. Okay. And then the second parameter is the well-known P.OC. And the P.OC is the change between the pressure at the start of the effort and, sorry, I'm checking because there was okay. And the pressure at the point at the lowest point during the inspiratory effort. Important, this is tidal breathing, and the patient, we don't need to tell the patient to do a maximum effort. We don't need to let the patient know that we're doing the occlusion. This has to go unnoticed in order for this maneuver to be a true reflection of what's happening during tidal breathing. Okay. So about About P.1, 2 words, 3 words is one, be aware of the different ventilators measure P.1 in different ways. So there are some ventilators like the ones on the left that you have to activate a maneuver. And what the ventilator does is it performs a short occlusion before the next breath, and it truly measures the drop in airway pressure during 100 milliseconds. And there's a second type of ventilators where the P.1 is displayed on a breath-by-breath basis. And it estimates the P.1 based on the drop in airway pressure during the trigger phase, okay? Why is P.1 a good measure of respiratory drive? Because it measures the drop in airway pressure at the very beginning, which is very sensitive to changes in drive. When patient has a very high respiratory drive, then this initial drop will be very steep. When the respiratory drive is low, it will be more shallow. And then it will change the value. Low values of P.1 is low drive, high values of P.1 is high drive, okay? And the second is that this initial portion is not associated with any changes in respiratory drive, okay? It's not affected by the occlusion. And lastly, even if the patient has neuromuscular weakness, they are able to perform a steep initial drop in airway pressure, even if they're unable to generate a full effort. So this dissociation in patients with high drive and a low effort does not apply to this maneuver. We are still able to measure a high P.1 if the patient is weak, at least to a certain degree. Okay, so we did a study to validate the use of P.1, the one that is directly displayed on the ventilator screen, and we showed that different ventilators, P.1 correlates with alternative measures of respiratory drive. And the other nice thing we showed is that we can use extreme values of P.1, less than 1 and more than 4 centimeters of water as estimates of effort, okay? Reasonably accurately. Then other scientists did show that P.1 value, extreme values of P.1, as the study from that I show you, do correlate with the meaningful outcomes. So one is P.1 measured during the first 24 hours of patients being communicative is associated with patients' mortality. So very extreme values, higher mortality. In parallel, it's also correlated with dyspnea. And then another more physiological study showed that patients that have higher P.1 values during the first day to transition to pressure support have higher risk of failing the transition. Okay, so that's P.1. And then the last one that it might be challenging to understand, but it's important for you to know because we're using it regularly in practical, is what we call POC. I already explained what it is. So it's the drop in airway pressure during an expiratory occlusion for a whole breath. So it's measured from the start of the effort until the nadir. And we need to do some corrections to be able to estimate the effort without the occlusion, because as you see here, the drop in airway in pleural pressure during the occlusion is larger than without the occlusion. So there are two things that we can do. The first is to estimate the inspiratory effort or P-mass, okay? In order to directly estimate P-mass, we just multiply POC by 3/4 of 0.75, okay? And it will give you the POC during the unoccluded breaths. The other great thing about POC is it allows you to measure the total driving pressure during the unoccluded breaths, okay? And I put the analogy of the iceberg again. So we have the positive pressure from the ventilator and the negative pressure generated by the patient, okay? And how do we estimate this? So first, we need to estimate what's the negative pressure generated by the patient, okay? Which is a value slightly lower than P-mass. If you remember my slide when I show you what P-mass actually is, because we don't need to add the chest wall recoil pressure. So first we multiply POC by 2/3 or 0.66, and that will give us this negative deflection. And then we add this value to the positive pressure delivered by the ventilator, okay? And we have what we call the total driving transponder pressure dynamic. Why dynamic? Because this value includes the pressure needed to generate flow through the airways, not just the inflation. Okay. If we don't remember how to do these things, we don't need to. We just go to a web page called rtmaven.com. On the left upper corner, you see the address. And then you go to the PIOC option, and it will give you a reminder on how to do this. So you just input the values that you got. So the peak airway pressure, for example, if the pressure support is 5, PIP is 5, peak airway pressure will be 10. The PIP 5. Baseline pressure when you perform the end expiratory hold is usually the same value as the PIP. And then what's the value of the peak drop? And then you press calculate, and it will give you the values. I think we're running a bit out of time. Kathy, maybe tell me if we have a few more minutes.
Yes, we do. It's until 5 o'clock. Yeah.
Oh, okay, we have time. Okay. Yeah. So I have a video. I don't know how many of you have done this, but I have a video to demonstrate on a patient on a fake patient how to do this. And I will walk you through. So this patient is on pressure support. Sorry, I'll go back. Let's see here. You see pressure support is 5 and PIP is 5, but we have no idea of how much effort the patient is doing. Okay. On the same patient, we have esophageal pressure inserted. Okay, so this is real. This is the same patient. So we see on the top, we have the flow tracing, then the airway pressure tracing, and then the esophageal pressure tracing. You see the cardiac artifact. And we see how for each respiratory cycle, he's doing very small efforts. You don't see here the values, but at first glance, it's doing very small efforts. The easiest way to estimate, we're not going to calculate P mass just looking at the tracing, but at least the negative deflection. How much is it? Okay. So I think I posted at some point. Yeah. And we measure it here. So for example, in this breath, it's only 3 centimeters of water. That's extremely low. Okay. So, but we don't have it usually in clinical practice. So we're going to see if we do P.1 and POC on this patient, what would be the values. For this ventilator, we go to the respiratory maneuvers. We are starting with PIOC, okay? So this ventilator particularly does not allow you to perform a regular end expiratory occlusion when the patient is breathing spontaneously. So you have to use a maneuver that is called NIF. NIF, it's negative inspiratory force, and it's meant to do it with maximum effort. We are not doing that with this maneuver. Here, we're just using the maneuver, but allowing the patient to continue breathing spontaneously, okay? So we applied the occlusion for the duration of only 1 breath. You see, there's 1 negative deflection, that's it. And then we release the occlusion. So this ventilator will actually directly give you the POC value, which is the actual delta, okay? Oh, sorry, I started again, but I wanted to continue. Okay. Oh, I put the different video. So then we need to input these values on our rtmaven.com. So remember 7.3 negative, okay? Or -7. So we go to our rtmaven.com. This patient was on pressure support of 5 and 5. So we would input here. Peak pressure 10, PIP is 5, baseline pressure is 5, and then the peak drop is 5 minus 7.3, okay? So it's, let's imagine 7, 5 minus 7 is -2. So here we would put -2. In other ventilators, instead of doing this sort of maneuvers, what we do is we record the tracings, we perform an end expiratory occlusion, and then we scroll with our cursor through the waveform, and then we're able to measure the baseline and the value at the peak drop. okay? And once we input these values, the calculator will give you the Pmass predicted and the total driving transpulmonary pressure predicted. Okay, and here I put you some general reference values. For low values for Pmass would be 3 to 5. For high values for Pmass, I'm getting higher and higher as time goes. Here I put 10 to 15, but I would say 15, yeah, 15 to 20, or yeah, around that. For total driving transpulmonary pressure, up to 25, 23 to 25 centimeters of water. That's very high. Okay. And since we have a few more minutes, I will just show you, in case you were not aware that we can do this, is what happens when we do an end inspiratory occlusion during assisted ventilation. Okay. Think inside you, what are you expecting to happen if the patient was breathing spontaneously? We do an end inspiratory occlusion. Will the airway pressure? So first thing, the occlusion principle holds. So that means that any change in pleural pressure will directly transmit to the airways, okay? So if we do an inspiratory occlusion, so the patient takes a breath, the air is still inside, and we perform an occlusion. What will happen with the airway pressure? Will it stay the same? Will it go up or will it go down? Think 1 second. And then we'll see it live on a patient. And then I will explain why. Okay, so let's see what happened in this patient. So this patient was on pressure support of 5 and 5, and we perform an occlusion. And you see, we are recording, in this case, we are recording the maneuver, and then we are able to scroll through and measure it. But you see, this is the airway pressure. Here is the trigger phase, and then the pressurization. This is the insufflation on the flow, and then you see zero flow, okay? With the zero flow, the airway pressure goes high. Why is that? So we remember, the respiratory muscles contract initially. They generate negative pressure in the pleural space that generates a gradient that triggers the ventilator, receives the positive pressure. The negative pressure is still pulling the patient. And when we finish insufflation and we close the airways, what usually happens in most cases is the respiratory muscles relax. With the airways closed, the respiratory muscles relax. So what happens is the same that it would happen if that patient was insufflated passively with the same amount of volume, okay? The chest wall that is relaxed will try to come back to its resting position, and the pleural pressure will increase, and this will be transmitted to the airways, okay? So what we're actually seeing is the negative pressure. Imagine if we had esophageal pressure here. The negative pressure that the patient is doing here is now, because the muscles are relaxing, is now being transmitted to the airways, and we are seeing it upwards, okay? So this is a different parameter that we can use to measure that is called pressure muscle index, or PMI, okay? What is PMI? Is the difference between the peak pressure or the airway pressure at the end of insufflation and the airway pressure once the respiratory muscles have relaxed and that pressure has been transmitted to the airways, okay? What is this? Is this Pmass? No. This is the static portion of Pmass. So it's just the amount of effort that those respiratory muscles were doing just to keep a certain tidal volume, but not the pressure necessary to move the air in and out. Okay, so it's a little bit less than Pmass. It's the static component of it. If we're able to get this really nice plateau pressure during the pause, we can actually measure the true static driving pressure. And the value is equivalent to the value that we measure during passive condition. Okay. What's the problem with these maneuvers? Is that in some patients, here is the insufflation, the pause, you see that you never reach a plateau. So the pressure keeps coming up. And I didn't show you, and here you see an example where after going up, it actually went down. What happened here? When we perform an occlusion, instead of the patient's respiratory muscles relaxing, the patient started to push, which is a common reaction, not common, it's a possible reaction when the patients are receiving positive pressure, just the respiratory muscles are pushing. And then in this case, and then after pushing, then they took an inspiratory effort. Okay, so when this happens, the principles do not hold because the respiratory muscles are not relaxed, and we cannot use by any means any of these parameters for estimation of inspiratory effort. Just to show the clinical relevance, this is a study done by Alice Grassi here in Toronto, but with the group with Giacomo Bellani, which is who has been working on these concepts for a long time. And they also did an observational study. In this case, it was a multi-center study, and they also found that values of static driving pressure measured using this and inspiratory occlusion and values of dynamic driving transpulmonary pressure using the POC and then doing the calculation. Both higher values were significantly associated with worse clinical outcomes. Okay. So with this, I'm finishing. These are some of the take-home messages. So ventilators do not give any information on drive and effort. The drive can dissociate from effort when there is respiratory muscle dysfunction. There are several techniques, and each of them will provide a different and valuable information. Remember my road trip. So we start with the electrical activity of the diaphragm thickening fraction, measures derived from esophageal pressure, and then the specifics P.1, POC, and the inspiratory occlusion with the plateau pressure. And you can have more than one, and then maybe try to understand a little bit better how your control of breathing and respiratory muscle performance is working. Here, focusing on the main two that we can use at the bedside, P.1 and POC. So P.1 primarily measures respiratory drive, but also correlates with effort, particularly extreme values, less than 1 or more than 4. POC can we use to estimate two things: the muscular pressure, if you multiply by 3/4 or 0.75, and also the total dynamic transpulmonary pressure, swing or drive, and you need to multiply the POC by 2/3 or 0.66, and that gives you the delta pleural pressure, and then you add that to the positive pressure from the ventilator, and you get the total driving pressure, and it's quite accurate to detect excessive effort. And then when you use the ending inspiratory occlusion during pressure support, be aware of the details. You can not all, it has to be reliable to be able to use it. If you're unable to use it, we did a validation study a while ago where we found that a bit more than 70% of the occlusions are reliable, and the ones that were not reliable, so when it keeps going up and when it goes down, then it's usually associated with high drive and effort. So it's still informative, I guess. Before closing, I realized that I forgot to put my conflicts of interest. So my partner has a company that develops a medical device to monitor inspiratory effort, which is called MBMed. And I have given educational talks for different ventilator companies, Medtronic and Gettinger. Okay, with this, I thank you, and I hope to see you a spring day in Buenos Aires, or a fall night in Toronto, or anywhere else in the world. And we have 5 more minutes, I think, for questions if anyone wants to ask.
Irene, great talk. I don't have a question regarding this, but I sent you an email regarding this ATS document. Can you please respond to me when you have time?
Yes. This is for the
ventilator symposium. I have to confirm my speakers.
Yeah. I'm on. Yeah.
Okay,
Sorry.
you're good. I will let them know you confirmed. Alrighty, thank you.
My pleasure.
I have a question, if that's all right,
Yeah,
Irene.
yeah, go ahead.
Thank you so much again. A beautiful presentation as always. I got slightly sidetracked the other day reading some exercise physiology stuff, and
Yeah.
in that literature it says that for the same percentage of a maximal exertional effort, women express more dyspnea.
Yeah.
And it made me wonder whether there is a sex difference in, when we talk about like what normal drive is for between women and men. Like, do you know if there is a? I just made.
I
Just thought it was
haven't
interesting.
explored it. No. So I don't know. Well, because you applied, but in Canada we're forced to, whenever we apply for a grant, we're forced to disclose some of the nuances of gender differences in whatever research we're doing, etc. And this is one of the biggest one within our field. So but I haven't gone into a lot. I haven't seen if this is related to the perception of dyspnea or the actual drive on itself.
Yeah, exactly.
But it will there for sure be an avenue of research in the future to understand, because there's a full chain when we go to dyspnea. It goes from how much the local sensors are activated that might be related to the mechanics. I didn't discuss the influence of respiratory mechanics on drive, but the smaller your lung size is, the higher your drive is, because in order to get a certain minute ventilation, you need a stronger effort. And women definitely have a smaller lung size, which is something we're starting to look at in different studies.
That's not normalized to your predicted body weight then. So just smaller lung size, absolute volume.
Yeah, exactly. And the equations are totally wrong for women. Like the correction for women is definitely wrong. There were, I don't know if they already came out, but 2 ATS ago, there were at least 3 studies focusing on that. So that's one thing. And then here Martin is talking about progesterone and the stimulant, for respiratory drive, which is related to what happens during pregnancy as well, where your progesterone levels are higher. And then there's also the psychological component of dyspnea related to because it's actually a sensation. So there's a whole higher level processing of the information that those centers receive. That might more be related to the gender rather than the sex of the person, but we don't know. It's things that very interesting to explore. Yeah. It was the only thing that I could find when I wrote my grant related to maybe the gender. I said maybe it's worth exploring if there are cultural differences in the way we process suffering, and then maybe the gender can influence that different than the sex, for example, that might change the progesterone levels and therefore the drive itself. And so things to explore, but you have to go through the full pathway and maybe dissect on each of them what might be different between female and male versus women and men and or other genders. I don't know if there's any other. I hope that people, I don't know if there were other people that are maybe less experts and they're doing this at the bedside for IMB, if you find it useful, or if you have any questions and say, oh, now I understand what POC is. I hope. That was a little bit the goal. Okay, Kathy.
Great. Thank you very much, Irene. Seeing that there are no more questions, I'd like to thank everyone for your time for joining today's webinar, and especially thank you, Irene, for this wonderful talk. Enjoy the rest of your day. Thank you. Bye.
Thank you all. Bye-bye.